Hey there, and happy Tuesday afternoon. I am so excited to answer your questions today. I'm always really stoked when you send me questions, and I've got a great one today on functional neurologic disorders and equipment. This question comes up a lot. Before I dive in, if we haven't met, my name is Julie Hirschberg. I'm a neurologic physical therapist. I am the owner, the founder of Reactive Therapy and Wellness. It's in the Los Angeles area. And I also teach and mentor clinicians across the world in really complex cases, including functional neurologic disorders. This happens to be one of my favorite topics. And we had some great workshops last week, particularly on functional neurologic disorders, and I got some great questions. So I'm going to share one with you today. And also, if you are a clinician, our mentorship community is open now, and it's open through Thursday. So I'll talk about that as well. So here's the question. I'm going to read it for you. From a brilliant therapist. I honestly, the clinicians that send me things or in our community are brilliant because she starts the question with this. I know it always depends on the patient, which it does. So thank you for saying that. But what are your thoughts on bracing a person with functional neurologic disorder? And then she goes on to describe how she had a patient who was really plantar flex, and it was hard to get her to take steps, and she was working with a coworker and trying to get bracing, but got some pushback on that. And this is a common kind of piece that many clinicians try to weigh is, should I use equipment? Should I use bracing? How do I use it? And honestly, there's not an easy answer, except to listen to your patient. Always listen to your patient and what they need. That is the easy answer, but I'm going to go into more nuance. And this comes up as a question because, where is my ability to share a picture here? I'm not seeing it. Hold on here. Let me see if I can find it. It's not in its normal spot. But it's been like a week since I have done a live. I might not be able to share a picture. So I was going to share a picture though. I could show it to you here. This picture, this table, it's from the consensus guidelines in functional neurologic disorders for physical therapy, and it has general treatment principles for F&D. And literally one of those principles, two of them actually say, avoid use of adaptive equipment and mobility aids, though it says, though these are not always contraindicated, and avoid use of splints and devices that immobilize joints. So it's no wonder that some people might read that, and then you're pressed with a patient that might need something, and they're going, well, the guidelines are telling me not to. So again, my first piece is to listen to your patient. What are they telling you they need? And number two is take the guidelines with a grain of salt. I actually don't agree that you would avoid these things, but that you would take into what is going to be most helpful for the patient. So I want to give you a couple of guidelines for this. And I'm just going to be in here also just checking out the chat. If you've got questions about them, shoot this my way. So number one thing that I think about, and I've discussed this with other clinicians as well, I know I'm not the only one that disagrees with that part of the guideline. So first, what you want to think about is, what is that person's goal? And would a piece of equipment or bracing help achieve that goal? And what is their function like with and without that? So a really good example is a wheelchair. If a person is asking me for a wheelchair, and that's going to increase their participation in life and independence and function, like that's kind of our common sense as PTs and OTs. We're going to look for a way to do that. Now, is there a downside to a wheelchair? Yeah, you're not upright. You're not on your feet. You're sitting. There are some downsides to that, but that's a great conversation to have with your patient and weigh what is the benefit to that cost. Does it mean that person's independent? Maybe they can work. Maybe they can be more mobile. Maybe they can go to Disneyland. Maybe they can tolerate more activity because they have the opportunity to sit. So that's a good example of one piece. Somebody else is asking about bracing. And I'm so glad you said this. I can't share a picture, but I brought in another article because this person is asking about individuals with functional neurologic disorder and hypermobility. We see this a lot. So if you're a clinician seeing somebody with FND, you absolutely should be screening for hypermobility. In fact, you should just screen it in all of your patients. It's quite prevalent and it makes a difference. We know that bracing in hypermobility is very beneficial and maybe even needed and required. And in fact, I brought in a piece of literature. I'll give you the name of it since I can't pull up the picture. First author is Song and colleagues. It's from 2020. It was a retrospective review that looked at Ehlers-Danlos syndrome and treatment. And let me just actually pull up this quote. OT and bracing, so occupational therapy and bracing, were the most effective options for treatment in EDS, particularly pain management. 70% of patients reported improvements. Hello, if we are not considering bracing of some sort in hypermobility, we should reconsider. And because it is so common in functional neurologic disorders, this is why I actually think the consensus statement could be faulty. We actually wouldn't want to avoid bracing for some folks. And the question went on to limit movement in a safe range or to control pain, right? So that person can move more freely. Now the question also is, or does that stop the brain from learning that control? So I think the other piece that's really important that I always think about, not just for bracing, but for all of the interventions, how little can we use, right? So do we have to lock an ankle or a knee, or can we actually provide more movement and use soft bracing? So we use, for example, the body braid a lot in folks with hypermobility, and we use it for folks with functional neurologic disorders. It's a great sensory input too. So I would go, how little support can we give to get the result that we want? And I would say the brain might actually learn some more automatic movements because that person has control. And I think this is no different than I wear custom insoles in my feet because I have funky feet issues. And does that mean my brain's not learning to walk and to run? No. Does it mean I can still do those things barefoot too? So there is a component that I really appreciate of variability in our training. And this is why what a brilliant question, by the way. This is Carrie asking this. Because you're thinking about these things and you're thinking about how is this person learning to move. So what I always think of is, let's have a conversation. Let's listen to the patient. Let's weigh those pieces together. And if the bracing or if the assistive device, mobility aid of some sort, allows them to experience safety and movement, that is actually going to allow the nervous system to relearn. One of the key components, and again, I wish I could share my screen, and for some reason I can't. One of the key components in that physical therapy guidelines is to build trust, build safety. A safe nervous system is a nervous system that is ready to learn. So fighting or arguing about an assistive device or bracing, not building safety. And I'm not saying, Carrie, that you were fighting. No. But I think sometimes as therapists, we can come in with sometimes a bit of an ableist perspective that like no devices, and the consensus guidelines kind of led us astray a little bit in that way. I think they're well-meaning, by the way. I think they're written by a fabulous group of people, but we have to listen to the person and provide safety. And that safety might mean bracing. It might mean a device. It doesn't mean it's forever, but that might be for the first steps. And then we can kind of build a graded exposure to not using that potentially. So what a great question. Somebody else asked, what if FND only presents intermittently with triggering emotions or idiopathic causes? This is very common that some of the signs and symptoms either worsen intermittently or only come intermittently. And in between, the person is functioning fine. That is really common. And I think, I'm not sure if you're asking about bracing with this, but I might look into and screen if that person has some other components that might be contributing to the FND, and like a hypermobility disorder, or POTS, so maybe dysautonomia. That's another group that we might use compression, for example, and that's really, really helpful. And I would never want that person to try to function without it, because they may have an episode. There might be pieces for intermittent symptoms. I often look at the sensory system and the autonomic system. We might want to build supports in for that person in between. Another really great assistive device that we think about is augmented communication. So also in FND, what we understand in the literature, what we see clinically, is there's a higher incidence of autism. Some people may need other forms of communication, and we should use that because the person being able to communicate and connect is much more important than them, not being dependent on a device, which I think is kind of a misnomer. What about Bionis or walk aid? Love it. What a great question. I've definitely used neuromuscular electrical stimulation or devices like that, and I think they can be really helpful for people. The nice thing about those devices too is you can change the settings so that they're a little bit less, and that's something that you could like graded exposure or graded I wanted to say de-exposure. I was just making up a word. I think you know what I mean, but we could actually slowly turn that down as that person recovers the ability to walk. And this is where I think some of the misunderstanding in FND and use of devices is that it's like so different from other neurologic disorder. And it is different, but also these are very real foot drops that we're seeing. These are very real weaknesses that we're seeing, and they deserve assistance and help just like you would for a person post-stroke or with MS. So I think the Bionis walk aid is a great idea. Or too much stimulation. So this has come up too. I was talking to another one of our therapists where the bracing was actually too much stimulation for a person. And I was like, hadn't really thought about that. But the body braid, for example, which can be worn over the whole body and provide some compressive forces at the joints, really helpful for hypermobility. It's also a lot of touch points of the body, and it can be too much stimulation. So again, this is why this is such a brilliant question from this therapist. It's so person specific. Bracing could be too much for a person. What a great point, Sarah. Hannah asks, what are your thoughts on weight training alongside proprioception exercise with FND to continue progressing? I love it. I love weight training. So what a great question. What I love about weight training is the weight. it's such a great sensory tool and proprioceptive tool. So if people are able to do weight training, I would absolutely encourage it. I might even, if they have, if we've kind of analyzed some of the sensory components and they need more sensory input, I might even consider doing some weight training with eyes closed to ramp up the proprioceptive piece. Brilliant question. Love it. Let me just make sure I'm catching everybody's questions. Thank you for the question. So I was going through a few questions to kind of ask yourself with the bracing and training. What's the person's function like with or without it? What's their quality of life and participation with or without it? Are there some things that the person is fearful of doing and the device helps them to participate in those things? Or does it actually hold them back from doing those things? And then making that a part of the discussion with the person. The other piece is thinking about what are some of the cons, or what are some of the things that can go awry with the device. So, in the person, for example, who's hypermobile, and we might be using crutches or a walker, there might be a heavy load on their wrist and arms. And so we want to weigh that with the person and consider maybe other options for them that is less on their joints. Similar for a wheelchair or a scooter. Are there some detriments maybe with that person with dysautonomia who really benefits from a muscle pump? Do they not get that in the wheelchair? Can they limit the amount of time they're in the wheelchair so that they have less time in sitting? But again, that is very person specific. I see another question here. Let me grab this. Do you think the Locomat or robotic equipment could also be overstimulating? What a great question. So the Locomat or the robotic assisted bikes or treadmills, walkings, and things like that, they could be overstimulating for a person. Absolutely, they could. They could be helpful for a person too. Although I will say one of the things that is really big in neuro rehab in general right now is high intensity training, high intensity gait training. This is not a principle that really applies to functional neurologic disorders, nor does it apply to people who have hypermobility, nor does it apply to people with dysautonomia. So don't apply that concept with these folks. And so a lot of those training devices are indicated to try to increase repetition of steps. That is not really the driving philosophy or understanding in functional neurologic disorders. What we want to instead is try to drive goal-oriented automatic movements. And I would say something like a robotic assisted device or a Locomat, so like a treadmill training, it takes the whole goal-oriented piece of things for automatic movement kind of out of the picture. And so I'm not saying I wouldn't use it. Like, I would never say never. And I believe in a lot of creativity in applying to treatment. So I'm not going to say never use that type of device. But what I would ask is, when people are thinking of a piece of equipment or like a special technique, what are you trying to do neurophysiologically for that person, right? We should ask that question. What is and this is why we have our pie chart, what is the underlying neurophysiologic issue for this person? Is it autonomic? Is it motor control? Is it sensory? Are there actually lifestyle, psychosocial pieces? Are there physical impairments? And then we set up our intervention to match that. So great question. Now, somebody else asked, a mirror isn't helpful, correct? Actually, I think a mirror can be very helpful, particularly mirror therapy. So mirror therapy is part of graded motor imagery. It's been shown to be helpful in some subtypes of functional neurologic disorders, especially pain. And it's been really shown to help rewire that map of the person's limb in their brain. So mirror therapy can be extremely helpful, and you can do that with video, you can do that with mirror. Now, I don't think, Sarah, maybe you weren't exactly asking about mirror therapy. Just using a mirror for feedback could or could not be helpful for a person. I think one of the things that we think about that goes awry in the brain in a person with functional neurologic disorders, or might be part of the picture, I should say, because we don't know this is the case for everybody, is attention. And attention to, how I'm moving, what muscle is contracting, what my foot and what this joint is doing, and I gotta get my foot in this particular rotation and in this position and my trunk here. And that internal focus can actually cause some of the functional neurologic disorder. We know and understand that attentional focus kind of hijacking the brain, and then automatic movement is suddenly frozen. And so using a mirror, like I'm thinking back to like my days of being dancer and constantly looking in the mirror and constantly analyzing, is my hand in the right place? Are my fingers doing the right thing? Where's my foot? All those things. I was terrible at pointing my toes, always could see it in the mirror. That kind of mirror feedback might not be helpful for the person who we're trying to move the attentional focus to a goal, versus what that movement looks like, or what joint is here, and so on. So I think in that case, Eric, it might not be very helpful. However, we have some folks that have really experienced a disconnect from their body, and they're actually not feeling anything in their body. And sometimes actually having the mirror and getting a positive experience helps with body awareness and proprioception. So maybe you know this by now. I'm going to say never. So it's not always avoid equipment, and it's not always avoid a mirror, and no robotics ever, but to really think about the person in front of you and what their nervous system needs. Another person asked, early aggressive movement when first gaining muscle contraction post-SCI versus letting the nerves heal. So this is an entirely different discussion there, because there is some evidence of early mobility after things like spinal cord injury and stroke that can be very helpful. That doesn't really apply to functional neurologic disorders. I will say what does apply is early on, the person who experiences functional symptoms is getting a diagnosis, understanding, and experiencing safety. And so maybe one of these days we'll have like the safety trial, like how early can we help a person experience safety in their body? And that might mean that they need sensory input. It might be an autonomic piece. It might be that they experience a fracture in their ankle and they need some stability there. It can be so many things, but safety, trust, number one. So the early mobility for other acute neurologic injuries is really an entirely different topic than what we're talking about in functional neurologic disorders. So great question. So we talked today about a great question that one physical therapist sent me about bracing and equipment in people with FND. It's not an avoid it all of the time. It's not a never. And in fact, I think when we look at comorbidities, especially with hypermobility, it's something to really consider for people who have FND. And, but it's not in all ways, right? So it's a nuanced conversation that I think we really have to think about person by person. And that's exactly what we do at Reactive. Honestly, like I'm part of a team right now, and we've been talking about this with a particular patient, and pros and cons and where might we start. I mean, it's really, really individual. And I think having a team with the patient as the center of the team is really helpful. The patient should be driving the bus on those decisions. And as therapists, myself included, I've been a therapist for a long time, and I really grew up with a lot of ableist conceptions about equipment. And so I think I have to check myself and check the ableism that I experience, and let patients guide that for themselves. So that's just something that I've learned. But these kind of questions, these nuanced conversations, these person-specific mentoring and discussions, this is what we do in our Brain Bites community. And I love it. I love working with other clinicians. I love discussing these cases in depth. I love getting to know my fellow clinicians on a deeper level. Our community's not huge. It's a small community on purpose because we really focus on not only these professional growth topics, but topics of taking care of ourselves as therapists. I think this is really important. People with complex cases need amazing clinicians. And sometimes those clinicians that take on the complex cases get burnt out because they're the only ones. And that's not because of the patients. I think it's because of the systems that we have in place. And so we just really need more support. So this is one of the main whys behind our Brain Bites community, and one of the main reasons too that if you're a clinician and you join today, so it's only through tonight, we are offering a one-on-one mentoring package where we get to meet with you as a group and then individually 3 times. So I get to hear these questions. We get to talk about them. We get to problem solve together. We get to talk about your life as a clinician and where you are on the roadmap, and help you really feel connected to your next right step as a clinician. So if you're a clinician, we would love to have you as a part of the community. I see Sarah asking, I focus on ASD. Autism, is Brain Bites something I can look at? Absolutely. So we have clinicians, pediatrics, adults, PTs, OTs, social workers. Sarah's a recreational therapist. Absolutely. We have personal trainers. We have yoga therapists. It's an interdisciplinary community. It is for professionals. We have other great things and groups for patients, but this is a community for professionals, and it is really, I think, such a different learning experience. I think as professionals, we're really used to going to classes and getting CEUs and going to conferences and, maybe even being part of other big learning experiences. And this is different. This is for that clinician that works with autism, that loves advocating for their patients with diagnoses that maybe aren't well understood, that wants to take care of themselves so they can be in this profession forever. That's what I want. So our community is open through Thursday. You can join us at reactiveeducation.com/brainbites. And the special mentoring package is just available today. You have to sign up today. So I hope you will join us today. I see another question coming in here. Do you accept foreign educated PTs with pending licenses? Yes. So we do have therapists in our community from all over the world, which I love. We have a huge group from Canada. We have people from Singapore. It's really phenomenal. And I think it's because like-minded clinicians who have really big hearts, who want to think outside of the box for folks with complex cases, they join us from all over the world. So yes, absolutely. You asked about pending licenses, by the way. So we do have students or very new grads in our community, and there's a special discount. It's 50% off. I do not want you to pay full price if you are new as a clinician. So send me a message or a direct message or email to ask for that discount code so that you can get 50% off. So this is for therapists that are students, that are brand new grads, or just completed a residency. So you're new, you're just getting started. We want to make it really accessible and affordable to you. So it's 50% off. I'll send you that discount code. Just send me a message and I'll get that your way. So if you are a clinician, our doors are open through Thursday. So just 2 more days, but today only is the day for this special mentoring package. We want to get to know you. We want to help you in your roadmap in life as a therapist. I'm going to just scroll through here, make sure I didn't miss another question here. But I just want to thank you too. Thanks for joining me. Thanks for asking really awesome questions. I love when you send questions, and you're not alone in those questions. Like you're not the only person that sent a question on bracing and F&D, for example. So I'm so thankful for that. Thankful for you. And if you're a clinician, I hope you'll join us in our community. We're really creating a movement for people helping folks with the most complex cases. So thanks for being here. I just appreciate all of you, and I will see you again soon. Have a good night.